एक minute. Okay, all right. Let's go.
Uh, good, uh, Good morning, good afternoon, everybody. I am Rishika Karki, a specialist in poison information in the Poison Information Center, Nepal. Today, I'll be briefly talking about paraquat poisoning. So here's the outline for today. First, I'll briefly introduce things about paraquat poisoning. Then we'll talk about a case that we received in our center 4 days back. Then we'll talk about new therapies for paraquat poisoning. Then we'll briefly discuss a few question and answers if there's any, and the challenges that we have faced during this case. And then there's the resources that I used. Introduction: Paraquat, diquat are bipyridyl compound which belong to herbicide. Paraquat can also be absorbed through skin, but poisoning most usually follows ingestion. Severe paraquat toxicity is severe paraquat toxicity is characterized by multiple organ failure, principally involving the lungs, kidney, and liver. In less severe poisoning, also, the lung is the major target organ, and respiratory failure is the most common cause of death. Paraquat is absorbed rapidly but incompletely from the gut. Less than 10% of an ingested dose is absorbed over 6 hours, with peak plasma concentration that are attained within 4 hours, and it is excreted renally. So, mechanism of toxicity of paraquat. Paraquat is thought to exert its cellular toxicity by undergoing cyclical oxidation and reduction to produce free radicals that damage the lipid membrane of cells, including inducing cellular injury and death. These free radicals lead to formation of other reactive oxygen species, which are also cytotoxic. So, to classify, paraquat toxicity can be classified as mild, moderate to severe, and then acute fulminant poisoning. So mild is when there's 20 mg of paraquat ion per kg body weight ingested, where patients are usually asymptomatic or they develop site vomiting or diarrhea. Moderate to severe poisoning is when there's 20 to 40 mg of paraquat ion per kg body weight ingestion, where patients suffer from vomiting, diarrhea, and then they also develop generalized symptoms that are indicative of systemic toxicity. Pulmonary 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 fibrosis develop Pulmonary fibrosis develops in all cases, but they recover. But few recover, few don't. There's also renal failure and sometimes hepatic dysfunction as well. Then there's acute fulminant poisoning, where there's ingestion of 40 mg or more of paraquat ion per kg body weight, where in addition to nausea and vomiting, there's marked ulceration of the oropharynx with multiple organ failure. In this group, mortality is almost always 100%. Death commonly occurs within the first 24 hours of ingestion, and it's never really delayed for more than 1 week. So, clinical manifestation of paraquat toxicity. Initially, there's nausea. Okay, clinical manifestation. Initially, there's nausea, vomiting, diarrhea. There's burning sensation, soreness, and pain in the mouth, throat, chest, and abdomen, which is usually epigastric. There's also cough, which may be productive and blood-stained. There's acute respiratory distress syndrome that manifests as dyspnea, hypoxia, and increased work of breathing. Convulsions, though rare, they have been reported, but it's mainly due to cerebral edema that's precipitated by fluid overload. For dermal exposure, there's burns, blisters that can occur, and also nail damage. For ocular exposure, there's stinging sensation in the eye, inflammation, ulcer, and formation of a pseudomembrane as well. So this is a general approach to a patient with paraquat poisoning. This is based upon TalkSpace. So this is very brief. I will talk about more modalities later. Initially, we take history and examination, where it usually comprises of the compound ingested, the amount, the time, and the strength of the ingested compound. We check the oral cavity, skin for any corrosive injury, burn, and other possible route of ingestion. We check the vitals, chest, and abdominal examination, which is crucial for paraquat ingestion. In investigation, we've divided it into general and specific. For general investigation, it's complete blood count. There's renal function test, where AKI can be seen due to renal tubular necrosis. There's LFTs that we have to do because hepatic necrosis eventually ensues. There's urine analysis, and there's ABG. ABG usually shows the picture of acidosis. It can be respiratory, metabolic, or even lactic. In specific investigation, we have urine paraquat and spot urine sodium dithionite test, and then there's serum paraquat test, which unfortunately it is not available in Nepal, I think. Imaging, there's imaging where we do ECG and chest X-ray. There's also toxicology panel if available to rule out other co-ingestion, which is also unfortunately not available. For management part, it basically depends upon the amount and dose of the ingested compound and the time since exposure. So at first we start with the decontamination, which can be done via activated charcoal or lavage by seeing the ability to protect the airway and caution with the corrosive effects as well. This can be done within 2 hours or sometimes even 3 hours of ingestion. Normal decontamination also has to be done, which basically comprises of washing your body with soap and water and undressing all the exposed part, undressing the body, undressing the clothes uh, as well. Then we have to monitor vitals and ECG and serial pulse oximetry. We then send out the investigations as listed above. Rest of the part is pretty easy. It's just symptomatic management. We avoid oxygen because it enhances toxicity. There's adequate fluid hydration has to be done, and we have to maintain good urine output. However, we cannot we have to be very careful of fluid overload as well. We give antiemetics if there's any vomiting, and for pain alleviation, for corrosion, we usually treat it with opiates. So this is a general management that's basically been derived from Talkspace. So now we start with the case discussion that we received 4 days back. So far, our center has received 2 herbicidal agent inquiry, and we will be talking about the one that we received a few days back. So the patient presented to the ER of hospital at around 11 p.m. 5 days back with complaints of multiple episodes of vomiting with nausea and mild abdominal pain. The 22-year-old had consumed 20 to 30 ml of a liquid called Ginny, which was later identified as Paraquat. Patient consumed the liquid after having an internal quarrel with her family at around 7 p.m. There is no other relevant history, no previous suicidal attempt. We received this call from the ICU after 21 hours of ingestion of the substance, not from the ER but from the ICU. The substance was identified as paraquat, and the call was actually made to see if there was any antidote available, and there was also a decreased urine output of the patient. So it's evident that the patient was starting for it was AKI was beginning in the patient, acute kidney injury. So these are the lab investigation, as we can see. This is the first day of the investigation. First day investigation. RFT is normal, LFT is normal. Other tests are also fairly normal. This is the second day. The second picture is of the second day investigation, where we can see that the RFT is deranged. Her urea is 60, her creatinine is 2.42, and sodium and potassium are normal. So this is the second day investigation after, let's say, 24 hours. This is after 24 hours. This is the third day investigation of the patient, where we can see even more deteriorating urea creatinine. Even calcium was extremely low in this patient. ABG, we also have the ABG report. The day one ABG shows a picture of metabolic acidosis. Unfortunately, lactate was not available in that place, so we don't have that report. The day two of ABG also was quite similar to the first one as well, which also showed a picture of metabolic acidosis. Day three, the patient collapsed and expired, so we don't have the reports. To briefly describe it, the patient had presented with vomiting and nausea. Upon examination, she had normal vitals in the ER, except from respiratory rate, which was on the higher side. The patient underwent decontamination with activated charcoal 3 hours after ingestion, and then she was managed symptomatically with antiemetics, PPI, and IV fluids, and she was also given a dose of antibiotic. Because her urine output was also, she didn't have good urine output, she was later given furosemide 80 mg. And her 24 hours intake and output are as follows. Her intake was 5,300 ml and the output was 640 ml with 8 episodes of watery stool. So the advice from Poison Information Center that we gave was to maintain adequate hydration while being cautious of fluid overload. Dexamethasone 8 mg TDS IV, and acetylcysteine, sodium bicarbonate, and calcium infusion for acidosis and hypocalcemia, as it was shown in the investigation before. On day 3 from her home center, she was referred to Kathmandu or high center because of her declining status. And on day 4, early morning, she collapsed. So the prognostic factor for paraquat toxicity is plasma paraquat concentration at the time of ingestion that we can see. This is, however, not relevant to us because I don't think we have that measurement as well. Um, this is if it is 2.0 mg per liter at 4 hours. If it is less than that, she's likely to survive. If it's more than that, then it's almost certain that death is near. This is a normogram, which also predicts survival of the patient. Uh, there's also a term called a severity index of paraquat poisoning, which is calculated by multiplying the plasma concentration by the time since ingestion. Here, the SIPP or severity index of paraquat poisoning, if it is less than 10, it predicts survival. Between 10 to 50, it predicts death from lung fibrosis. If it's more than 50, it predicts death from circulatory failure. Our patient had collapsed from, I think, as I couldn't really confirm it with doctors, but according to the talk that I had with the patient party, I think she had developed lung fibrosis because she was feeling respiratory distress because of respiratory distress. So for context, in Nepal's context, what we can do is for the prognostic factor, we have renal function test, which predicts survival, and then we have lactic acidosis, which predicts death. So renal function test, the rate of increase in serum creatinine concentration, it correlates with survival. An increase that is less than 0.03 mg per dl per 5 hours over per hour over 5 hours associated with survival. So if in 5 hours, if there's 0.15 mg, less than 0.15 mg of increase in serum creatinine, then the patient is likely to survive. Whereas if there is an increase of more than 0.04 mg per dl for over 6 hours, it is associated with death. The part of serum creatinine rise is also due to increased production that is driven by muscle oxidative stress. The other thing that we can monitor is lactic acidosis. Severe acidosis following volume resuscitation reflects the severity of poisoning. There were 2 retrospective studies done which showed that the lactate concentration above 4.4, the first one, and the second study above 3.35 millimole per liter respectively, was associated with fatal outcome. So basically more than 3.35 millimole buoyancy, there's bad prognosis. There's also a thing that was written in Goldfrank that I would like to share. It said that the prognosis in patients presenting with more than 12 hours after ingestion 50 ml or more of paraquat of 20% strength, those with a positive plasma diethylene test, which is not available in our center, or those with a SIPP greater than 50, is told that treatment should focus on symptom control and end of life support and palliation. So we can assume how bad it can get. So new therapies for paraquat poisoning. There is no known guideline for paraquat poisoning management, and the treatment can be divided so broadly into 3 portions, as I read this in papers and other books as well. So the 3 components that we can divide the management is preventing the absorption of paraquat, the removal of paraquat, and alternative and additional therapies. Preventing absorption of paraquat, it can be done by gastric lavage, followed by a dose of activated charcoal, which is usually done, given that the airway can be protected and has been presented within 2 hours of ingestion. Removal of paraquat can be performed through hemoperfusion, most preferred, then hemodialysis, and continuous veno-venous hemofiltration. It has been suggested that removal of paraquat of blood hemoperfusion provides better clearance of paraquat than hemodialysis, and that the use of hemoperfusion within 12 hours of poisoning may reduce mortality. Treatment with the hemoperfusion for 4 hours, if it can be initiated within 4 hours of ingestion, has most benefits. In one study, survival rates for patients who received early hemoperfusion were more than double than those who did not receive hemoperfusion. So the alternative and additional therapy are immunosuppression and an antioxidant therapy. We give dexamethasone 8 mg intravenous every 8 hours for the first 72 hours to patient with acute paraquat poisoning. Combination of cyclophosphamide and glucocorticoid has not been, however, validated by rigorous study, and it is not recommended as a combinative treatment, but it has been employed at a lot of places. It was found that patients who received antioxidant or immunosuppressant therapy in addition to hemoperfusion, cyclophosphamide, methylprednisolone, vitamin E, vitamin C, and acetylcysteine, had better survival rates compared to those who received hemoperfusion alone. However, I also found a study that vitamin C actually did more harm than good. So we have to be very cautious while using these agents as well, because it has not been studied. And also these studies are extremely contraindicate. These are also extremely in opposing ways to each other as well. So there are various other treatments have been studied in animals, including pyrifenidone, complement inhibition, civilistat, bozetan, P, sulfonatocalixarine, dimercaptopropane sulfonate, ambroxol, sucralfate, bone marrow, mesenchymal stem cell transplantation, and selenium. But however, human data is lacking for all of these. We have no evidence to recommend treatment with any of these regimens. There's also sodium salicylate 200 mg per kg, which decreased reactive oxygen species production and inflammation and improved survival in rats, but not in humans. Again, coming to the prognosis part, there's another that was written which said the prognosis in patient presenting within 6 hours of ingestion of less than 50 ml of paraquat, those with faint positive dithionite test, or those with SIPP less than 50 is also poor, but however, prompt and multimodal treatment with volume resuscitation, oral activated charcoal, hemoperfusion or hemodialysis, intravenous corticosteroids, acetyl salicylate, and acetylcysteine, deferoxamine, and vitamin E can be considered on case-by-case basis. It cannot be overemphasized that potential benefits of these treatment is extremely time critical, and it must be immediately given. So these are a few test reports that I studied, out of which I think only these two survived. Rest, all of the cases had expired out of the ones that I read. So a 66-year-old male who ingested 10 ml of 20% paraquat that was mixed with alcohol. Initial paraquat concentration was 0.24 microgram per ml, who received 50 grams of activated charcoal, IV NAC. 4-hour hemoperfusion was also performed for 3 consecutive days after admission, with hemodialysis commenced on the 4th day after uremia. The patient developed hemolytic uremic syndrome, macroangiopathic hemolytic anemia, thrombocytopenia, elevated reticulocyte count, and lactate dehydrogenase on day 9. Plasma exchange was also performed 3 times consecutively, after which anemia and thrombocytopenia improved and LDH normalized. Urine output normalized on day 18 of admission, and hemodialysis was discontinued. The patient did not develop any long-term sequelae, so he survived. So there's another case of 24-year-old female who was admitted to a hospital 2 hours after ingesting 50 ml of paraquat. She developed pulmonary fibrosis and severe respiratory failure. 34 days after ingestion, the patient was intubated and mechanically ventilated. She was started on vivovenous ECMO whilst awaiting a lung transplantation on 44th day. On day 56, she underwent bilateral sequential lung transplantation. The patient underwent respiratory and physical rehabilitation. She was extubated on day 66 and was discharged on the day 80. At 1 year follow-up, the patient was well and pulmonary function test was also improving. So challenges that I faced for this case, number one being the limited information on Talkspace. General management protocol, it was very general. The management protocol was extremely general and it was not detailed. Thanks to our expert panel and everyone at TUTH who helped with this case, we were able to give thorough information to the hospital. So another challenge for this case, for specifically this case, was could early hemodialysis have been beneficial for this patient? So this is also very controversial because there are contradictory studies. There are a lot of contradictory studies. According to a study, hemodialysis did not reduce the mortality in paraquat poisoning cases. However, it should be mentioned that other variables such as amount of paraquat ingested, vomiting after ingestion, time of ingestion to hospital admission, performing early gastric lavage, or administration of active charcoal The severity of paraquat intoxication based on serum concentration, the interval of time to start hemodialysis, and duration of hemodialysis sessions are extremely crucial for survival and mortality, and it should be considered for decision to perform hemodialysis. According to another article published, in case of lethal dose of ingestion, hemoperfusion is not useful at all. And in borderline lethal ingestion with presentation within 4 hours of exposure, hemoperfusion may benefit as the poison may not have been distributed into the tissues. So lastly, in a study, it was published that on a controlled trial on the outcome of combined continuous veno-venous hemofiltration and hemoperfusion in paraquat poisoning, they concluded that treatment with combined continuous veno-venous hemofiltration and hemoperfusion significantly improved the 90-day survival rates in paraquat poisoning. So these are my resources. Thank you, everyone. If there's any questions, any feedback, highly appreciated.
Amazing job, Rishika. That was fantastic. Really, really good presentation. And I know this was a tough case. I was on shift. I was seeing the messages and a few things that I noticed. I think from this, I think the experience, it sucks. Like Paraquat, if somebody, I don't think anyone has answers to Paraquat poisoning. It seems like from all the literature search and what you have presented. And when somebody decides to take Paraquat, it's pretty much like almost a death sentence, it seems like, depending on the doses. But one thing that with Nepal, what is the situation? And maybe Dr. Rakesh has answer to this, but what's the situation on availability of Paraquat, and like what is the more upstream approach of how to what is the epidemiology? Do we know the epidemiology of Paraquat deaths in the country? I know South Asia has a really high rate overall around the world, but I don't know specifically Nepal's data.
Uh, so shall I answer the question? Okay. So first of all, Rishika, thank you very much for the wonderful presentation. And Dr. Ramu, the answer to your question is yes, paraquat is very commonly used as an herbicide in the South Asian countries, and in Nepal it is less commonly used because it is used to protect the crops in the, like for the, if there is high huge amount of, like this, I mean to say like this, if there is huge amount of landfill where more herbs are produced. So it is used in the large scale, not in the small scale, because we don't have the, our geographical condition. We don't have the huge scale of farming to protect the crops from the herbicides. So it is more commonly used in Pakistan, I'm sorry, and China. And if you see the use of this herbicide in Nepal, there's very limited, use of this herbicide. And if you see the literature review of the poisoning of this paraquat in Nepal, we can see very limited, poisoning you can see in the literature review. So I went through the literature review and I have found only 3 or 4 cases of paraquat poisoning in Nepal. So, and out of them, one got survived, and the other 3 they died. So it means like they are high mortality rate with the ingestion of this paraquat poisoning. And we have been trying to regulate this paraquat from Nepal. So we had planned to regulate in 2019 from the Ministry of Agriculture and Livestock Development. The reason we could not provide the evidence was there was less poisoning due to this paraquat. So, and I looked, now we are looking at the impact of the ban of 2019. I look at the data that we have been collecting for the last 2 years, and I found only one data on the paraquat poisoning.
Okay.
So it means like there
so
is
not a super known high burden in the country, but maybe it's just not, a lot. I figured with Paraquat, maybe, how, Risha, can you remind us what was the onset? So if somebody takes Paraquat today, what is the onset of the first symptoms? Is it very quick, or does it happen after a number of days? What was that?
Several symptoms, they start very quickly. The peak plasma concentration, according to TalkSpace, is 6 hours. According to UpToDate, it's 2 hours.
Okay.
So,
and then it's eliminated renally, or
yeah,
through the liver?
renally.
Yeah, it sounds like maybe hemodialysis could have some benefits, just thinking of, even looking at our patients, like, just renal function getting low, but it didn't seem like the renal function was that bad unless on the third day where we don't have the data
Yeah,
from
yeah, yeah.
the renal function sort of zoomed,
Yeah.
yeah, it went crazy. But it seems like more of a multi-system related death rather than just a renally induced also, because we would have a little bit of time. So it's a pretty quick onset, huh? So I wonder if there are people that, even before they get to the hospital, we have lost people from these, and we don't really know. So there might be a lot of cases with that. Rishika, can you also describe a little bit on your experience of using the international expertise? I know that, there were a few people that were very active. Did you get what you needed on timely manner? Did you think that, we could improve some of that process? How was that? How was that for you as the person that was supporting?
Actually, for me, the international team was of extreme help, to be very honest, because when the call came, I was actually just leaving from my house from TUTH. So I just briefly looked into Talkspace, and there was no antidote. I had no idea about how severe it could get. I had not really dwelled into paraquat poisoning, and I had no idea it could get this bad. So it was only when I reached home and I saw everybody's messages, and I realized, oh, okay, this is something very difficult. So I actually they were of huge help because there was very limited data in Talkspace, and thanks to the international team and Praveen sir and Akriti ma'am and TUTH team as well, who were back and forth supporting me. So it was very easy, and I really appreciate the help as well. So things that we lacked in Talkspace, thankfully we had the team to back it up. So yeah.
Yeah, unfortunately, I don't think any database will have good answer, because it doesn't seem
Yeah,
like
yeah.
there is a good answer in the world.
Okay.
And that's the classic, thing with toxicology, is a lot of it is supportive care, and sometimes it really
Mm.
depends on the dosing that a person has taken. And then I don't think there is any utility of GI decontamination on this, right? Like I know that activated charcoal is indicated, but like things like gastric lavage and things like that don't really make sense for this. Is that correct?
Yeah, yeah. So let
Yeah.
me. Oh, okay, Rishika, please. I have
No,
a.
no, भन्नुहोस् न, please.
I don't know. Please. You first. You want to answer them?
मैले चाहिँ त्यही त्यो स्टडीमा चाहिँ सुरुमा चाहिँ एक्टिभेटेड चारकोल अनि त्यसपछि चाहिँ सरी लभाज अनि एक्टिभेटेड चारकोल गर्ने भनेर चाहिँ मैले भेटेको थिएँ एउटामा चाहिँ
Mm-hmm.
त्यो त्यति हो चाहिँ म त्यही भन्नु आँटेको थिएँ। हजुर
Okay.
भन्छ न।
So if you see the article published that was published in 2022, the results showed that there is no effect of the antiemetic in the paraquat poisoning. So hemoperfusion and hemodialysis could be one of the potential therapies for the treatment of paraquat poisoning. As of now, the recent development in the paraquat poisoning.
Yeah. Okay. Awesome. Does anyone have Rishika? One thing I didn't see was liver enzymes on the labs, like especially if looking at liver function, like INR and maybe bilirubin level. I didn't see that. Was that done, or do you know if that was not done?
I don't think it was done because when I asked for all the investigation, they'd send me all those investigation. The day one they did the LFTs, but then because it was normal, they didn't repeat it the next day, and the third day they had already referred her to Kathmandu. So I don't think they did it. So we don't have that data regarding that.
Yeah, I wonder if, because it seems like this is very corrosive, and, of course, there's a free radical issue. So I wonder if there is, sort of signs of just severe anticoagulation and like severe sort of
Yeah.
liver failure also that could be leading to. Anyways, quite interesting. Does anyone else have anything to add?
Rishika, this case could be one of the potential candidate for our case reports. Is there any photos, any manifestation that the patient had? Do you have any information on that? Any photos or anything like that from the patient?
I have X-rays, sir. Most X-rays is all.
So that could be one of our, that we can use in our case report. Maybe you can contact to the person from the respective hospital. We can give him the principal author if he wants to be. Otherwise, if he wants us to write the paper, we can give him as a co-author and we can write the paper. Maybe.
हाम्रो यो केस चाहिँ फेरि सर हाम्रो फोरेन्सिक ल्याबमै आउनु भएको रहेछ कि उसको लागि त्यो अटोप्सीको लागि सो फोटोज चाहिँ उहाँहरूसँग पनि हुन्छ कि इफ वी
Okay,
आर रियली
that's good.
इन्ट्रेस्टेड।
That's good. त्यो भने तिमी you can go to talk to Gopal Chaudhary. You take my name, मेरो नामले, अथवा Dr. Akriti is here. Maybe she will help you with the forensic lab. You can, if you can, you can take photo from them. If that's possible, you can contact to Dr. Gopal Chaudhary, who is the head of department of forensic department. So Dr. Akriti is here. Maybe she will facilitate you with Dr. Gopal.
Yeah, Rishika, I think that definitely we should write this as a case report. One, Nepalma Paraquat ko धेरै case पनि रहन्छ हैन, we just found out, so this would add to the literature. And then number two, I would be careful with the please with the photos, make sure you guys are doing appropriate consenting with the family and things like that. We don't want, I mean, even if we don't have photos, we can write this as a case report. And we can write it from the PIC perspective, right? We can write it of, a case comes to the PIC, and Rishika, you can be the lead author, and that's fine, and write this. I think this would be a really good case, a really good learning. Like, I think this was probably the toughest. Just looking back, I think this was the toughest case we've gotten in since the PIC came. So I think, Rishika, you did a fantastic job. Like, very, very proud of you, the work you did. And I'm really thankful for our local experts, including, Dr. Akriti and Praveen, and I know Dr. Rakesh was involved as well as our international experts, Ziad Kazi, and I think one more, I don't know how to pronounce it.
Dr. Eric.
Dr. Eric, yeah.
Dr. Eric.
Very, very helpful. So did they end up giving cyclophosphamide? Do you remember? Or did they end up giving dexamethasone?
Only dexamethasone. Cyclophosphamide was not available.
Yeah. Not available. Okay. Fantastic. This is great. Great case discussion. Lovely. All right. If we're done with discussing this, maybe we can move on to our weekly meeting, and we can stop the recording now, probably.
Yeah, okay. Rishika, I have a few suggestions to your slides, okay? So if you don't mind.
Sir, please.
Okay, then I will stop the recording and we can discuss.
Okay, you can stop, yeah.
Any more questions? No. Thank you.